All right, I think we're going. I want to say thank you to Dr. Bluming for coming back to answer some questions. We did a webinar last week talking about navigating menopause after breast cancer. And not surprisingly, there were a million questions, almost 100, really specific questions. So we're going to try and get through as many as we can. I might have to bring you back for another session. But what really got driven home for me reading all of these questions is what happens when a woman gets a breast cancer diagnosis. All of a sudden, she's expected to become an expert, both in breast cancer types, breast cancer treatments, breast cancer, everything around breast cancer, while managing her own experience and just feelings and emotions about what's happening. So I thought that was a really interesting thing to realize and think about, what a difficult time this is for women, and how difficult it is to access the information and to become knowledgeable in such a way that you can then make an informed decision. And for that reason, I would like to introduce you to Dr. Avrum Bluming. I am Monica Molinar, one of the co-founders of Alloy Health, a telehealth and pharmacy platform centered around giving women information, access to expert doctors, and the solutions to handle menopause. But we don't know everything about breast cancer and handling breast cancer after menopause after breast cancer, which is why we have invited Dr. Bluming back to answer some specific questions. So thank you, Dr. Bluming, for joining us here.
Nice to see you again, Monica.
I'm going to jump in. These are really specific, so I think it's important, to give everybody set the stage that we are not giving personal medical advice. We are asking Dr. Bluming for his opinion on specific questions based on his experience as a breast oncologist and expert in the field of hormones, hormone replacement therapy, estrogen, and breast cancer. So hopefully that's fair. Okay, question 1. Do you have to wait 5 years from your DMX nipple sparing, no lymph node involvement, HER2 negative, ER plus PR plus before you start HRT if you have had no radiation or chemo?
Okay, the problem is it sounds like a specific question. And so let me just reiterate that we will provide as much information as we can. But our information should be used in discussions with your physician so that you reach a shared decision and not used as if this is specifically given to you. Having said that, the short answer is no. We don't force women into menopause right after an ER-positive breast cancer. Because the negative ramifications of that would outweigh potential benefit, especially with a small ER-positive, PR-positive, HER2-negative tumor. The question in this case, of course, is was radiotherapy eliminated because the physician counseled that it wasn't necessary, or was it eliminated at the patient's insistence? Not all women require radiotherapy, but it's important to speak with the physician and ask, what are my chances at this point, having completed therapy, of having a recurrent cancer if I do nothing else, versus what are my chances of having a recurrence if I start taking hormone replacement therapy? And the answer to that should help guide the course of action.
Yeah. Is it possible to know what the evidence that we have is that there's low chance of recurrence from hormone replacement therapy?
It's more specific than that. There are actually nomograms that are available online that allow a person to input the size of the tumor, the absolute estrogen receptor activity, the presence or absence of lymph nodes, even the histologic type of the tumor, whether the HER2 gene is amplified within the tumor, and get a reasonably good projection of what the likelihood of recurrence is with and without additional treatment. Doctors can't always keep those numbers in their heads, and they consult that kind of nomogram frequently.
Is that something that patients are able to consult on their own? Or you really have to do it through a doctor? A doctor can get that information.
There are several, and I think they are open to the public. I don't have at my fingertips the websites for them, but you and I can communicate after this, and if I can find any, I will send them to you.
That would be great. We'll put them in the show notes. All right, question 2. We got to move through these because there are so many. I had a stage 1 ILC and went through radiation. I've refused AIs. Is that a mistake? I'm 53, already have horrific menopause symptoms brought on by going off HRT when I was diagnosed with breast cancer.
Okay, first, ILC is infiltrating lobular carcinoma, and it's important to know that that constitutes only about 15% of all diagnosed breast cancers, and therefore the data we have on lobular carcinoma is less voluminous than the data we have on the much more common infiltrating or non-infiltrating ductal carcinoma. Having said that, the question that has to be posed to the physician is, given the stage of my tumor and everything you know about it, what is my likelihood of recurrence if nothing else is done? What would be my likelihood of recurrence if an aromatase inhibitor, what you called an AI, is used? And what are the negative benefits, negative side effects of aromatase inhibitor use that I might experience, so that doctor, you and I can sit down and evaluate what the best course of action would be for me.
That's great advice. I'm going to try not to react to all of these. I'm just going to keep plowing through.
Good luck with that.
When mentioning breast cancer, do you also include ER/PR positive breast cancer? Like let's just, I guess, take a step back and talk about what we're talking about when we talk about breast cancer, which is there are multiple different types. Maybe that's
these are the ways we subcategorize breast cancer once it's diagnosed. First, is it invasive or is it intraductal, meaning it hasn't spread through the cell membrane? Intraductal breast cancer is usually very, very early. It usually carries a superb prognosis. In some cases, just cutting it out, depending upon its size and the way it looks under a microscope, may be enough. Invasive ductal carcinoma means it has already spread through the membrane of the duct. It is not quite as curable as intraductal, but currently invasive ductal carcinoma, if it's early, carries a 90+% cure rate with appropriate treatment. In order to determine what the likelihood of recurrence would be, we look at the following characteristics. We look at the size of the primary tumor. And the size of the primary tumor carries prognostic significance. The smaller it is, the better. 2 centimeters or less, which is a little less than an inch, is stage 1. If it's 1 centimeter or less, it's even better. If it's a half a centimeter or less, it's even better than that. We then look to see, is it multifocal? Is it present in several parts of the breast, or is it unifocal? And that can often be picked up with the initial mammogram or an MRI scan. Obviously, unifocal is better than multifocal in terms of minimal treatment. The next thing we look at is the number of lymph nodes that are involved with tumor. We used to do extensive axillary dissection, taking out many lymph nodes under the arm as part of staging. And as a result of studies, we now know that a sentinel lymph node is often good enough, which carries much less morbidity than exploring the axilla. Sentinel lymph node means you inject a small amount of blue dye or a small amount of radioactive material, and you then look at the nodes in the axilla, and the blue node is the node that preferentially accepts the drainage from the breast. You remove the blue node, or the node that has some radiation emitting rays that you can identify. You examine that under the microscope, and if that node is negative, you stop, and you don't have to take out additional lymph nodes under the arm. Obviously, no lymph nodes is better than one. One is better than four. Four or more is considered more serious. Now, none of these mean, oh my God, this is a fatal disease, but we're talking about levels of prognosis. We then look at the tumor that was taken out to see if the tumor cells have on their surface a receptor for estrogen. Now, what most people don't recognize is cancer cells usually start as stem cells, very primitive cells within the breast. They constitute less than 5% of normal breast cells, and they help replace breast cells that grow old and die. And stem cells are typically estrogen receptor negative. Acquiring an estrogen receptor is a sign of maturation of the cell. And a mature cell multiplies less rapidly than an immature cell. So a cell that has estrogen receptors on its surface is a slower growing tumor, generally carries a better prognosis than a cell that is estrogen receptor negative, which is less mature. And progesterone receptor is a way of burnishing that. An estrogen receptor positive, progesterone receptor positive breast cancer has a better prognosis, size for size, lymph node for lymph node, than an estrogen receptor negative, progesterone receptor negative breast cancer. We then look at something called the HER2/neu gene. HER2/neu is a gene that is present in every cell in our bodies, male and female, and about 30% of breast cancer patients have extra copies of this gene, or what is called HER2/neu amplification, which means higher activity of the gene within the cancer cell. That used to be a very serious problem because HER2/neu positive breast cancers were much more aggressive. Thanks to the work of people like Dennis Slayman at UCLA and other oncologists around the world, we now have drugs like Herceptin, which neutralize the effect of HER2/neu amplification and eliminate the negative prognosis associated with that characteristic of the cell. Finally, we look at something called Ki-67, which is a measure of the proliferative activity, the speed at which the cells are multiplying within the tumor. The higher the number for Ki-67, the larger the percentage of tumor cells that are multiplying at any one time. So ideally, we'd like to see a tumor that is 2 centimeters or less, ER positive, PR positive, HER2/neu not amplified, with negative lymph nodes and a very low Ki-67. Would you like to take a 30-minute break and think about all that, or should I continue?
No, this is actually the most amazing description of breast cancer I have ever heard. And I finally almost understand all of these terms. Because what's interesting, I think, is that people hear estrogen receptor positive breast cancer and think, oh, for sure, I definitely can't take estrogen because my breast cancer is fed by estrogen. So if I have an estrogen receptor positive breast cancer, that means no estrogen for sure. And what I'm hearing is actually totally not that
I'm
case.
so glad you raised that. What you are hearing is not stating that I understand the leap from saying I have an estrogen receptor positive tumor, which means my tumor was caused by estrogen. We have to learn from the extensive experience that we are accumulating every day. And what we know now is estrogen receptor positivity doesn't mean that you've got a skull and crossbones on estrogen pills or estrogen patches that may be in your medicine cabinet. We originally know that tamoxifen, which was introduced as a breast treatment, was described as an estrogen receptor blocker. And that made sense. If estrogen attaches to an estrogen receptor on a breast cancer cell and stimulates it, and we can block estrogen from gaining access to that receptor, then tamoxifen must be working by preventing that. Well, tamoxifen does work. It's helpful in the treatment both as adjuvant, meaning to prevent recurrence, and in the treatment of measurable breast cancer. But because our initial understanding was that it works by interfering with estrogen gaining access to the estrogen receptor, the guideline was it must never be used in premenopausal women, because premenopausal women have elevated circulating levels of estrogen, and those levels would prevent tamoxifen from competitively filling the estrogen receptor site. So it was recommended it be used only in postmenopausal women who have low levels of estrogen, and therefore it would be more effective. That makes sense, but it didn't work that way. Turns out tamoxifen is even more effective in premenopausal women than it is in postmenopausal women, and that in spite of the fact that when tamoxifen is administered to a premenopausal woman, her level of circulating estrogen can increase 4 or 5-fold.
Wow.
And so we no longer call tamoxifen an estrogen receptor blocker. We now call it a specific or selective estrogen receptor modulator. What does that mean? I don't really know, but it's fuzzy enough that it allows us to continue giving tamoxifen to estrogen receptor positive women without having to explain exactly how it works. It's important. Just let me add one other thing. Tamoxifen has been shown to be effective in some patients who have estrogen receptor negative breast cancer, and it is effective when it works in about half to 60% of people who have estrogen receptor positive tumors, not all. So we still don't understand clearly exactly what tamoxifen is doing, although 10 modes of action have already been identified independent of blocking the estrogen receptor on the breast cancer cell.
What does that mean, 10 modes of action? Like,
it means how it works. It works not just as a blocker, that is probably not even its principal activity. It works in 10 other ways that we know of, and perhaps in many others that we still don't recognize.
and is it working? It's working to prevent recurrence, or it's working to actually treat an existing cancer?
Both. It started by showing that women who had measurable tumor, largely those who were estrogen receptor assay positive, had shrinkage of the tumor when they were given tamoxifen. What we try to do,
multiplied their level circulating estrogen.
even though estrogen levels in premenopausal women rise dramatically, What we try to do is prevent recurrence, which is even better than treating inoperable breast cancer. And so if something works and the side effects are tolerable, we usually use it in what is called an adjuvant setting, which means the tumor has been treated with mastectomy or lumpectomy, with or without radiotherapy. And because we know, depending upon the prognostic characteristics of the cell, the tumor can come back, we use it to minimize the likelihood that the cancer will come back. And tamoxifen has improved the prognosis of those women dramatically and significantly.
And what are the side effects that somebody should expect or might expect from tamoxifen, or that have been seen from tamoxifen?
Well, they vary. They're usually tolerable. Some women will develop dry mucous membranes. Some women will develop joint pains, what are called arthralgias, although that's usually seen more with aromatase inhibitors, a different class of drugs than tamoxifen. Some people think incorrectly that tamoxifen actually induces menopause. Well, it doesn't. In premenopausal women, if you have dramatically elevated levels of estrogen, it's not going to induce menopause.
It's very confusing actually, why it would cause, if it's increasing levels of estrogen, why would it cause dryness, for example? But I guess in postmenopausal women who are no longer making estrogen themselves, when you add it, it doesn't do anything. It doesn't sort of create estrogen at that point, if you're menopausal.
Well, tamoxifen has some estrogen-like activities. Estrogen is beneficial for the heart. Tamoxifen shows some benefit for the heart. Estrogen can stimulate mucous membrane secretion, preventing vaginal dryness. Tamoxifen increases vaginal secretions, but often it does it by inducing some vaginal inflammation, and the secretion is a result of the inflammation. So it can cause vaginal discomfort rather than soothing pre-existent vaginal discomfort.
So if you are taking tamoxifen and you have vaginal discomfort and dryness, is it then recommended to use vaginal estrogen to combat?
Well, you have to speak to your physician, and there are vaginal lubricants that can be used and vaginal moisturizers that can be used. I am not aware of any significant report suggesting that vaginal estrogen in that setting is harmful, even if some of it is absorbed into the bloodstream. There are occasional reports suggesting caution, but the ones I read, I find unconvincing.
And are you saying that there are reports about using vaginal estrogen after any type of breast cancer, or only if you're used in conjunction with tamoxifen in postmenopausal women who are experiencing dryness?
There are physicians who will say, I forbid you from taking any. I don't agree with that recommendation because of what I just said is my impression of the literature.
Right. Okay. I think, yeah, what we have certainly understood from all of the doctors around us is that after breast cancer, vaginal estrogen is generally okay to use for most women.
I agree with that.
Okay. All right, let's get into DCIS quickly. There are a couple of questions on DCIS. If you could, one, define it, and then the two questions I have here is, one, I had a stage 1 breast cancer 18 years ago. This year diagnosed with DCIS in the same breast at age 60, was on HRT but told to come off of it. Now that I've had surgery and my DCIS removed, is it sensible to go back on HRT?
Okay, I'm just going to refer without repeating to the statement that I can't responsibly give advice to somebody I haven't evaluated in person. DCIS, as we said, is ductal carcinoma in situ. In situ means it is remained where it started. It hasn't broken through the membrane of the cell. It is not, at this point, an invasive cancer. It carries almost always an excellent prognosis. This lady had DCIS many years ago. She's been on hormones. She has DCIS again. The concern is, did the hormones cause the breast cancer to develop again? And the short answer is, I don't know. And I say I don't know about 30 times a day or more. And the reason for that is I don't know what causes breast cancer. And that statement is both an admission of humility, which is I don't know, and there's arrogance in it because nobody knows. And I know that nobody knows. Because somebody who develops breast cancer doesn't want to get it yet again, what we usually try to do is change the environment within the patient that was conducive to the development of the breast cancer. If she was on hormone replacement therapy, it is not unreasonable to say, well, let's hold the hormones for some period of time that is arbitrary. 6 months, a year, 2 years, you're 60, hopefully you will live a lot longer than that. You might hold it just to make sure there is nothing going on in your breasts that is affected by the hormones. And then if you are symptomatic or concerned about being deficient in estrogen, we should have another discussion to see pros and cons of resuming the hormones.
Okay, great. Thank you. Here are some questions about BRCA and the relationship between, I mean, we've been talking about the relationship of estrogen and breast cancer. We don't know exactly what causes what causes breast cancer, why some develop and different types develop. Can you talk a little bit about the risks of developing breast cancer for BRCA, for people who carry the BRCA mutation 1 and 2? And is there any difference in treatment for those people, both after a prophylactic surgery, mastectomy or ovarectomy, and how that all kind of plays together?
Let me answer the second question first. No, there's no difference in treatment. And for the most part, there's no difference in prognosis. It's not that BRCA contributes to a worse prognosis, it doesn't. BRCA, which is short for breast cancer gene 1 and gene 2, are gene mutations, and there could be many gene mutations within the BRCA genes that have no significance as far as we know, but there are at least 2 and perhaps 3 specific mutations called BRCA1, BRCA2, and sometimes BRCA3 that seem to put the patient at an increased risk of ovarian cancer, breast cancer, prostate cancer, obviously not applicable in women, but in a family kindred that has these abnormal gene mutations, that's been the finding. And because ovarian cancer is still so hard to pick up early, many women who are BRCA positive elect to have their ovaries taken out so that they're not at significant risk, which could be 50 or 60% risk of ovarian cancer, and that almost eliminates the risk completely. You'll notice I rarely talk in absolutes. I always stick in and almost, and that's only because you have to be careful. In addition, women who are BRCA positive have an increased risk of breast cancer. Instead of having a 1 in 7 or 1 in 8 risk, they can have a lifetime risk of 1 in 2. And so many women will have elective mastectomies to also dramatically reduce their risk of breast cancer. Interestingly, BRCA women who have their ovaries taken out when they're premenopausal eliminate the increased risk of breast cancer. Even without having the breast cancer taken out, if you have your ovaries removed, you not only reduce the risk of ovarian cancer, you dramatically reduce the risk of breast cancer. And the first thought when that became apparent was, well, of course, estrogen causes breast cancer. By removing the ovaries, we're removing estrogen. Of course, breast cancer risk goes down dramatically. However, there are now quite a few studies looking at what happened to these women who had their ovaries taken out. I'm looking at one who then went on hormones. And the concern was, my God, we're going to increase the risk of breast cancer again. No, that lowered risk of breast cancer remains a lowered risk of breast cancer in spite of adequate estrogen replacement. Why is that? There's number two. I don't know.
It's so crazy. I mean, that's really what motivated me to start Alloy in the first place, was my experience having my ovaries removed, not being able to get adequate help, care, answers to all of my questions when I went into menopause. And I still think it's a bummer because of, I think, the Women's Health Initiative and sort of the lack of interest, one, and two, just so much misinformation around this phase of life and hormones generally, and estrogen specifically. We've lost at least 20 years of really good data that we could have used to answer some of these questions. So now it's, we're starting a little bit from scratch, but hopefully we can, not really from scratch, but hopefully from here forward, we can start to really gather, a lot of this information so that we can be more specific with women about what it is that they.
And just following that, I don't remember if we mentioned this at the podcast we did, but Eric Weiner, the current president of the American Society of Clinical Oncology, which is the largest group of oncologists in the world, gave a presidential address 2 weeks ago at the annual meeting. And this topic of his presidential address was patient-physician cooperation. Obviously, you shouldn't be dismissed by a physician who doesn't want to talk about something you feel is worth talking about. And you should also deal with the physician, recognizing that he or she probably knows more about this particular subject than you do, because as you started this discussion by saying, a woman is hit in the back of the head when she's diagnosed with breast cancer, and very important decisions have to be made, and she has to rely on somebody to help her make those decisions.
Yeah, it's complicated, but the more informed we are, the better, and hopefully this will be helpful. Here's an interesting question. How should young women with ER/PR positive breast cancer in their 30s be counseled? The question here is, hormone therapy may mimic menopausal symptoms. It creates menopausal symptoms. However, actually, I shouldn't say that. I'm going to just ask the question. Hormone therapy may mimic menopausal symptoms. However, they may also resume cycles after treatment.
Okay, let's start by just separating anti-hormone therapy, which is what you really mean, which is medicine that is meant to interfere with hormone activity, although we did say we're not sure exactly why tamoxifen works the way it does, but aromatase inhibitors do significantly lower estrogen levels. Removing the ovaries does significantly lower estrogen levels, and there are symptoms that go with that. There is an article that was published, I think in the early 2000s, that said that young women have a worse prognosis than young women are more at risk of breast cancer than older women. Well, that's not true. And it's important to recognize that. The second biggest risk factor for breast cancer, outside of being female rather than male, is age. The older you get as a woman, the more likely your chance of breast cancer is. That's a whole other discussion. The 1 in 8 statistic is a misunderstood statistic. Actually, your rate can be 1 in 272 when you're in your 40s or 50s, and it can go up as you get older, but the risk when you are in your 40s or 50s is no longer there if you're in your 60s. So the risk doesn't accumulate. It's just, it gets higher as you get older, and at menopause, it continues going up, even if your hormones drop significantly. So that the advice I would give to young women is similar to the advice that I discussed when we spoke about the risk factors for breast cancer. It is worth mentioning that women who get pregnant after having breast cancer, and clearly that's a young population, have no negative effect on their prognosis if they get pregnant and deliver a normal child. There are some suggestions that they may even have a better prognosis. Based on that, and this is true whether or not a woman has an estrogen receptor positive or estrogen receptor negative cancer. There does not appear to be any discrimination between those two categories of breast cancer. Based on that, Ann Partridge at Harvard published an article in April of this year where she reported a study of premenopausal women who were treated with tamoxifen because of the concern that their breast cancer would come back after they finished treatment of the primary tumor. And many of them wanted to get pregnant and have children. And she allowed them to have a 2-year hiatus in the tamoxifen, during which time they could get pregnant, bathing their body in very high levels of both estrogen and progesterone. And 64% of them had normal babies, and some of them went back on tamoxifen after that. They were followed for a little over 7 years, and there was no increased risk of recurrence among those women who took the 2-year break in tamoxifen, flooded their bodies with hormones, and then continued, raising the question of why the black label is on every estrogen-containing substance marketed.
I mean, we have to get rid of that because it's
As
so
you know,
unfair.
that is the campaign.
Yes,
Yes.
it's so unfair to women. It just makes no sense.
Yes.
My mother passed at age 52 from metastatic breast cancer. As a result, I refused hormone therapy at menopausal age and suffered with major menopause symptoms. Now at age 70, I've been diagnosed ER/PR positive, HER negative. I'm not BRCA1/2 positive. Should my daughter at age 40 start hormone therapy, and at what age? Due to my familial cancer history, they recommend MRI diagnostic mammograms alternatively every 6 months. Is there any relationship between family history and ability to use hormones?
I like to give, as you well know, definitive answers. And here is a question that is a second-generation question on somebody whom I haven't evaluated.
Right. I understand. Theoretically.
But in general, it would be good to learn as much as one can about the family history. What kind of cancers, what kind of breast cancers were they? What the prognosis of these breast cancers were, before giving out this kind of advice. In addition, although you and I have discussed this at some length in the past, not everybody should automatically, when they reach a certain age, start on hormones. These aren't M&Ms, and I have nothing against M&Ms, but there are side effects to any prescription medicine. And while I think the benefits of hormone replacement therapy far outweigh the risks, it's an individual decision that must be made between a woman and her physician, and in this case, between this woman's daughter and her physician. But she should be well informed of what the benefits are and what the risks might be.
Right.
You can challenge me for more detail, but that's my first level answer.
Okay, that sounds good. I want to try and get through a few more of these so we can always dive back into some other questions if we want to. Here's a woman who's 53 and taking tamoxifen and suffering immensely from menopausal symptoms. Her hospital doctors in the hospital are very against her taking HRT. She had EP positive, HER negative stage 1 breast cancer 3 years ago.
Okay, first, the discussion should be what we've already said. Doctor, if I stop the tamoxifen now, what are my chances of recurrence? How much better are they if I continue the tamoxifen? How long do you plan to keep me on it? We started with tamoxifen being administered in a dose of 20 milligrams a day or 10 milligrams twice a day for 5 years. It was then extended to 10 years, although the data supporting 10 years are largely applicable to women who had positive nodes, not to women who had negative nodes, and many women don't need it at all based on risk-benefit analysis with and without it. There is currently a study of 5 milligrams, not 20 milligrams, a day for 3 years, which in early results seems to be as good as 20 milligrams for 5 years. That needs more data, but that's being followed very carefully. The crux of the question is, well, wait a minute. If tamoxifen causes dramatically increased levels of estrogen in premenopausal women without affecting its beneficial effects, what would be the harm if I, as a postmenopausal woman, now start taking low doses of estrogen? That question was raised by Craig Jordan, who is the developer of tamoxifen, called the father of tamoxifen. And his answer was, I really can't see any harm in doing that. I don't have data to support that. And data are very important when we don't understand what's really going on. But I value Craig Jordan's expert opinion in this situation.
Does tamoxifen stop your period?
No.
Okay, because that was one of the questions, is why does tamoxifen stop your period if it increases estrogen?
Here.
Okay.
Good, a legitimate question.
But it doesn't stop your period. It doesn't put
No,
you.
now, you can get somebody saying, wait a minute, I started tamoxifen and my period stopped. Well, okay. That doesn't mean it caused it. But I think the question is very well phrased. If really its effect on functioning ovaries is to dramatically increase the level of estrogen, it makes no sense that it would stop periods.
Yeah, it does not. Here's a question from somebody who was diagnosed at 29 with triple negative breast cancer, invasive duct. Her ovaries were removed at age 35. And per her oncologist recommendation, she's now 38. Is estrogen an option for her? She's always been told no hormones from doctors, but when she addresses her and when she asks about her cardio, bone, and urinary concerns, she's dismissed. Her biggest symptom right now is low mood and brain fog. How would you?
Did I hear correctly that she was hormone receptor negative?
Triple negative breast cancer, invasive duct, ovaries removed at 35.
Is she BRCA positive?
Does not say BRCA positive. Diagnosed at 29, now 38, suffering with low mood and brain fog.
This requires a very serious discussion with the physician. I don't understand why her ovaries were removed in this setting.
Okay, well, now the fact that they were removed and that she is 10 years out from her diagnosis of breast cancer, and she's suffering, what can she do to help herself?
Well, several things. First of all, I mentioned that an estrogen receptor positive cancer, which she didn't have, often carries a more favorable prognosis because it's a more mature cell and slower growing than an estrogen receptor negative tumor. And that's true. However, estrogen receptor positive tumors being slower growing can come back many years later, whereas estrogen receptor negative tumors, if they recur, usually recur within the first 2, 3, or 4 years.
Oh, interesting.
So the fact that she had a triple negative, which carries a guarded prognosis, breast cancer, and she's now 10 years post having that cancer, presumably with no recurrences, suggests that there is a good chance she may well be cured. And given her symptoms and that statement, an intense discussion with her physician seems to be in order for the physician to explain why hormones are being contraindicated and why her ovaries were removed in the first place.
Interesting. I find that there's a lot of, it's so difficult to make decisions and to get all the information. In particular, as I said at the beginning of this, you get thrown into this situation when you're facing your own mortality, especially at such a young age. You get a terrible diagnosis, and then all of a sudden you need to become the world's expert in every nuance and, and make all these big decisions. It's very difficult.
It is, and you want to find a physician who isn't messianic in her or his message one way or the other, but is profoundly interested in supported answers and shares that information with you. And ideally, that's the doctor who should be taking care of you.
Yeah. Here's a question about osteoporosis and AIs. Somebody already has osteoporosis and I guess got a breast cancer diagnosis and treatment, is being told to take AIs, but she wants to refuse it. Would that be bad?
If I don't want anybody to get the impression that we don't take breast cancer very seriously. You had your ovaries removed because you were concerned about it. I've spent the last 50 years of my professional life studying it. We take it very seriously. But what we're looking at is not one single factor in our prognosis. We all want to live as long as possible and as well as possible. And those are two very important considerations. It's not all about breast cancer. And it's important to speak with your physician about what the likelihood is of you living a long time and living well with and without hormones. Hip fracture is the most serious side effect of maturity osteoporosis, post-maturity osteoporosis. And almost as many women die each year in association with an osteoporotic hip fracture as die of breast cancer.
That's insane.
And not only that, it is an incapacitating problem which can dramatically affect the quality of your life. There are other treatments for osteoporosis, but there is nothing as good as estrogen. And that has to be discussed with the doctor without the patient shrinking away after being dismissed. Don't allow your physician to dismiss your concerns. It is your life and your well-being, and you are entitled to answers.
And your choice to make that risk benefit analysis for yourself also. And I mean, I've spoken with women who are suffering so badly that with menopausal symptoms, that they would gladly take a recurrence of breast cancer if they could at least, live their lives, get a good night's sleep, stop sweating, stop being so anxious, keep their job, etc. in the meantime.
I understand, being a physician's desire not to collaborate with a patient on a course of action that could be detrimental to that patient's well-being. I understand that. And there are some unreasonable demands that patients make of physicians. What we're talking about here are not unreasonable demands. We're talking about, as you stated, a balance of benefit and risk. And the person who will be the recipient of the benefits and the risks is entitled to a strong vote in which path is followed.
So on that note, do you have any specific talking points or recommendations that women can use when they go to their physician to get them to listen to their concerns and think creatively about the issues that they're dealing with, what they're trying to solve, and what the proper treatments are given those parameters?
Well, here are the simple facts that should be known to the patient and to the physician. 7 times as many women will die in this country each year of heart disease than will die of breast cancer. 7 times as many. And what most women say when they hear that is, sure, but old people die of heart disease and young people die of breast cancer. And if I have to die, I'd rather die when I'm old than when I'm young. Well, the fact is that over the age of 40, the risk of dying of heart disease for women is greater than the risk of dying of breast cancer over the age of 40, and the difference in risk in favor of heart disease grows with each passing decade. Estrogen reduces the risk of serious heart disease by 50%. There was an article published in the New England Journal in 1994, written by a cardiologist who subsequently went on to be the dean of Columbia Medical School, saying, hormone replacement therapy, it's time for action, not debate. 1994, was that 30 years ago? Oh my God, time for action, not debate. I mentioned that osteoporotic hip fracture is associated with almost as many deaths each year as breast cancer. Estrogen reduces the risk of osteoporotic hip fracture by 50%, better than Zometa, the bisphosphonates. Calcium administered to a postmenopausal woman not on estrogen does nothing to prevent that kind of fracture. If there's one thing women are more afraid of than breast cancer, it is Alzheimer's disease.
Rightly
Nothing
so.
works on Alzheimer's disease except estrogen has been shown to be effective prevention, not treatment, in, depending upon the study you read, between 25% and 65% of women. Nothing else touches that.
Amazing.
And doctor, I don't want to become cognitively impaired. That's incredibly important to me. In addition, estrogen decreases the risk of colon cancer significantly, decreases the risk of diabetes mellitus significantly, and it is the single best treatment for the symptoms associated with menopause, which we've gone into in the past, but can repeat if you want, which last a median of 7.4 years, affect 80% of women. They last longer in women of color, and they significantly impair quality of life and mood, to the point where many female health workers in England, and probably in the United States, but the article I read spoke about England, are retiring early because of symptoms of menopause. That's disgraceful and unfair.
Yep, I couldn't agree more. It's awful. That is why we're out here so hard, fighting so hard to get the information to women so that they can make better choices for themselves, so that they can stand up to their doctors and demand that they get heard and get the treatment.
And work with their doctors and demand that the doctors work with them.
Exactly.
Yes.
Well, that's a perfect place to leave us. We've used up our hour, so we still have more questions to go through, but I will try and get you back and to answer a few more next time.
Fine.
Thank
Okay.
you so much for joining us and for answering these really important questions. I don't know of any other place actually where, other than you, where women can get, such complete, thoughtful, coherent, concise, explanatory thoughts on.
It's important to know that I am not the only physician with these opinions. In fact, there are many physicians around the world who are working very hard along the same lines that we are working. The book I wrote, and this is not meant to be a plug for the book, but it is a plug, Estrogen Matters, is a detailed book that's written with specific references. And although it's written for a lay audience, it allows women to speak to their doctors and say, if you disagree with this, here are the references that this doctor quotes. Why don't you give me references or tell me why you don't agree with them? And you could look through all the references and get names of doctors from that. In addition, it's written with Carol Tavris, who's a social psychologist with a sense of humor and a very sharp intellect and wit, so that it's written for the lay public to be very readable, even though it's full of information that you can bring to your physician.
And as I understand it, Dr. Tavris wasn't really an estrogen expert before writing this book, but became an activist, kind of like the rest of us. Because once you understand what's happening,
yeah.
It's hard not to get activated by this topic. So again, thank you so much. We will put all the links to the studies that you have referenced, to your book, where people can buy it on Amazon or other places. We absolutely recommend that everybody reads it, and we will continue to answer these questions. Thank you.
Nice talking to you, Monica.
You too, always.
Okay.